Okay, good evening. Welcome to the Southeast Asian Thoracic Society School of Surgery webinar series. So for this evening, we have two distinguished speakers who will be talking about robotic thoracic surgery. Let me introduce our speaker. Well, before I introduce our speaker, I'd like to thank our sponsor for this webinar, DTG Medical from Da Vinci. And let me introduce our speakers for this evening. First is Associate Professor Gavin Wright. He's known for innovation in minimally invasive thoracic surgery, particularly complex VATS lung resections, and robotic thymectomy for thymomas and myasthenia. Well, over the last decade, Professor Gavin has augmented his extensive thoracic surgical experience with multiple research projects and collaborations, and he has published over 100 peer-reviewed journal articles. He is currently the Director of Surgical Oncology at St. Vincent Public Health Hospital and the Research and Education Lead for Lung Cancer at the Victorian Comprehensive Cancer Center. He will be talking about how to set up the Vinci Mediastinal surgery, tips and tricks. Okay, so for our next speaker, we all know our next speaker, Dr. Aneez Ahmed. He is currently the Director and Senior Consultant Surgeon at the International Center for Thoracic Surgery in Mount Elizabeth Novena Specialist Center in Singapore. Prior to starting his private practice, Dr. Aneez served as the head of service of thoracic surgery in the Department of General Surgery in Tan Tock Seng Hospital. He is recognized as the first in the ASEAN cohort to get a level 3 certificate specialist training in robotic thoracic surgery from the EACTS. He is currently the General Secretary of our society, the SEATS, and he will be talking about two topics: setting up the Da Vinci Lung resection and Da Vinci training and certification pathway for thoracic surgery. Dr. Aneez is also my mentor in robotic surgery. So to start off, may I call on Professor Gavin?
Yes, thank you, Edmund. Good evening, everyone from Melbourne, Australia. Tonight, as advertised, I'll be talking about how to set up robotic mediastinal surgery, particularly thymic surgery, but generally mediastinal surgery, as opposed to lobectomy surgery, which Dr. Aneez will be going through in the next talk. So I've been lucky enough to have worked on every single version of the Da Vinci robot. I was first very fortunate to be trained by Jens Ruckert at Charité in Berlin on the original Da Vinci machine, along with his assistant at the time, Mahmoud Ismail, who many of you may know is now the director at Potsdam. I then returned to Melbourne to use the Da Vinci S at Peter MacCallum Cancer Centre, where I had to be proctored by a urologist because there were no other thoracic surgeons doing robotic surgery. Once the program was established there, we were merged into the Royal Melbourne Hospital, and I used the Da Vinci SI there, which was good because we got to use an 8mm telescope, a bit less painful than the 12mm. And since 2018 at St. Vincent's Hospital, I've been able to use the state-of-the-art Da Vinci XI with the dual console. So I've really run the entire gamut of Da Vinci robots. So my tip for robotic excellence, my mnemonic is TIP. So you need the training to be right. You need to get your ticket, so you need accreditation. You need to have the right infrastructure and instrumentation. And then with the procedure itself, you need to learn the positioning and then the procedure itself. So the theory, which can be really accessed anywhere, I would advise people to watch lots of videos, both of the internal procedure, but also of how to place ports, how to handle the general conduct of robotic surgery. Conferences and webinars like this are obviously useful, but there are formal programs which are run by Intuitive, so you can do your online training, hands-on training with the robot, in-service training, and then do robotic skills work to actually get you proficient at the actual use of the robot in general, but then in related to your procedure, in this case, mediastinal surgery. You then would need to actually visit, I think, a site, a surgeon that's doing the procedure that you want, and then return when your time for you to do the surgery. We would recommend you having a period of proctorship, which may be 2 or 3 cases where an experienced robotic surgeon watches you and supervises you and comments on your conduct of the procedure. That proctor may become your mentor, or you maybe have a local mentor, and then obviously continuing development, you want to continue to improve. Now, if you're lucky enough to have a formal robotic fellowship, that basically rolls all that package into one experience, but remember that that actually only trains the surgeon in the fellowship. So unless you're going back to a unit where everything's well established, you need to consider how you're going to train the entire range of staff, the theatre technician, nursing, sterilisation, etc. So this is the training pathway on the online schedule for Da Vinci. You do your online training, which basically introduces you to all the robotic components and how they work. It takes about half an hour. Then you do an in-person, in-service with Intuitive. They'll take you to a local robotic facility. Most countries would have this available nowadays to actually learn how to actually do things like docking the robot, looking after instruments, etc. Then you need to do an online assessment, which is just a little exam online. And if you pass that, you then need to get used to using the robot. So they recommend 20 to 24 hours of actual practice on the robot. That can be done, I'll show you in a minute, using simulator modules and things. And then the technology training gets you your final sort of certificate from Intuitive to say that you are technically proficient in using the robot, and then you just need to go on and get your training in the actual procedure. So this is the online modules. You can pick things like the very famous C spikes, where you just put little rings on top of the spikes, or you run a ring across a roller coaster without touching it. There are suturing modules to practice your suturing. So all sorts of things there. And there are so if your local institution can afford them, they're actually they can actually purchase a procedure, a virtual procedure to do. So once you get your certificates, you need to get your hospital accreditation. So you need to have documentary evidence of your training. You need to get your proctorship organised. And as I said, remember to train all the staff, because it's no good if you know what to do and no one else does. And then I would recommend that you maintain a logbook of all your cases, video every case so that you can actually review what went well and what didn't. And tricky cases you can discuss with your mentor, or cases if you're going to go to more advanced cases, discuss those cases before you do them. So here's the componentry. This is the XI equipment. So the servo unit has the robotic arms, the 4 arms on it. The camera can be interchanged between the arms. All these arms are interchangeable. And there's a pivoting gantry, so you can actually push the robot in any direction and then swivel the gantry around to get your ideal positioning for the robotic procedure. The console itself, we have a dual console, which is a fantastic luxury to have, because we can train people very well with this. This is the simulator module down the bottom here, which you can just have independently running. You can disarticulate these and have someone training if they want while someone else is using the other. The robot stack has all the electronic componentry, the gas for insufflation. We still have a VAT stack because I actually use a standard 5mm telescope to get access to the chest. And I also have my video taping equipment on the VATS stack as well. So I use a 5mm 0-degree telescope for an optical port entry, 30-degree telescope to help find my other 2 ports. My assistant will have a 5mm grasper and a 5mm sucker in case we need to do anything. We need a specimen extraction bag of some sort, Foley catheter or chest drain. We'll go through what I do with that. I use 3 8mm robotic ports, a 30-degree 3D telescope. Sometimes I'll change back to the 0-degree because sometimes 0-degree gives you a nice angle for part of the operation, but usually the 30-degree. I use a harmonic scalpel in my right hand. I use a bipolar fenestrated grasper in my left hand. And if the thymic veins are substantial, then I use a robotic Hemalock clip applier. We make up our own cigarillos, little gauze cigarillos, which we can pass into the ports. I did roll up gauze originally. Now I actually just tie together a couple of neurosurgical patties, long ones, about so long. They're very useful for blunt dissection and just for mopping up any annoying bleeding. And some pipe cleaners to clean blood out of your port, particularly your camera port. A robotic monopolar hook can be used instead of the harmonic scalpel. And in fact, I've got videos of each of those to show the differences. For my positioning for mediastinal, particularly thymic, anterior mediastinal work, I actually bring the patient right over to the right-hand edge of the table so their shoulder is actually off the table and able to drop. And then I create with a bean bag hung excessively off the right side, I create a cradle for the right arm and drop the arm posteriorly behind the chest. So you can see it over here. Then I pad the table and put lateral supports in and then maximally rotate to the left as far as the table will go. So you get a sort of a half lateral with complete access to the right chest. I then configure the ports in a gentle arc around the breast here so that I have the bipolar left hand will be just behind the pectoralis in the anterior axillary line, the camera port in the middle here, and then right down on the costal margin was where I have the harmonic scalpel port. And this area needs to be kept very clear. So you want the beanbag and arm and everything clear down here because when you're looking 30-degree down, the telescope comes quite low here and you don't want it interfering with or hitting the bag. My additional tips is I insufflate CO2 at about 6 millimeters mercury. Very nicely contracts the lung itself and pushes the diaphragm down out of your way. Reverse Trendelenburg also pushes the liver and diaphragm down a bit. I recommend against doing any redo surgery. Always do a fresh chest if you're doing robotic surgery, if you can. If you have unexpected adhesions, then I recommend you divide enough of those with your VATS initially until you can get your robotic arms in and then switch to robotic because it's actually quite easy to divide adhesions once you've got access and the robot arms are in. You can even do a hybrid procedure for large tumours where, for example, you're worried that the nerve is very close to the tumour. So you use the robot to actually clear the nerve and do that part of the dissection, and then you can do your sternotomy or thoracotomy to remove the tumour. I've done that a couple of times. Here's an example of a case, young female, incidental finding on a coronary calcification CT scan. No myasthenic symptoms at all, in fact, no symptoms at all. and the solid lesion that looks suspicious of thymoma. So here's the port. This ends up in about the 4th interspace in the anterior axillary line. And it's placed in a more fairly horizontal direction towards the angle of Louis, the manubriosternal joint. This is the diaphragm down the bottom there. This is the costal margin port for the right hand. In general, the telescope and the right hand port tend to end up in the same intercostal space. And this is targeting of the tumour. So we aim it at where we're going to operate. And the robot will automatically work out the optimal position for the arms. We then modify the arms ourselves once we've got all the instruments in to make sure everything is best clearance. You can see here my fellow and registrar working out where everything should be. And you can see the harmonic scalpel does not have a wrist, so it's not as versatile as the normal wristed instrument, but basically you manipulate the tissues so that you get optimal angles of attack with the harmonic scalpel. But I think the versatility of the harmonic scalpel in this situation is very good. You can see you can just cut and dissect at the same time very rapidly. Here you can see it coming along the phrenic nerve, and even doesn't matter if I take the pericardiophrenic vessel, it just seals it off. So I can go quite close to the nerve without injuring it. I'll just fast forward that a little bit. Here we are going around the top and around the bottom of the tumour. In this case, a non-myasthenic, so we just pick a spot that gives us a good margin, come across the fat. And then join the dots at the top here. Now we get to the most important part of the procedure where we're starting to dissect the veins at the top. So it's clearing the fat above the left brachiocephalic vein and the caval junction there. And this is the tissue over the aortic arch, just under the brachiocephalic vein. And you can see you can just sweep and burn at the same time with the harmonic scalpel. So this is pulling the horns back down into the chest. So we basically gradually pull hand over hand, just get rid of any fat and adventitious tissue attached to the horn. And then we'll see in a second that we just tease the horn in. And in this case, the thymic vein is quite small. So when I find this, I then just use the harmonic scalpel to divide it close to the gland. So there's a little bit of a gap between the origin of the vessel. And then the most difficult part, I think, is getting that left-hand side of the dissection where you come back up to the vein here. Because the phrenic nerve obviously is coming forward a little bit closer on that top section, so you've got to be very careful. And often it's very fatty in that corner, so it is more tricky. So gradually I just work from one side to the other till I can see all the way around. And here we are, we're just about to release the whole gland. And then we place the tumour into an extraction bag. And rather than put a chest tube in, these days I just put a Foley catheter into one of the top port, and then have my anaesthetist re-inflate the lung. We put the other end of the catheter into a jug of water, and after the sutures are all placed, then that catheter is removed. And you'll see here, this is the immediate post-operative x-ray of this patient, discharged the next day, analgesic paracetamol, and it was a B1 thymoma completely resected. The next day, I had my fellow do the next case. This was a good case for a trainee surgeon. This patient had a variegated tumour that we presumed must have been some sort of germ cell tumour or something like that. And you'll see here, now when I'm the assistant on the twin robot, you see little green cones appear where I can instruct the trainee what to do or where to dissect next. You can see them just appearing in the screen there. And so this was a perfect case for a trainee just to get practice at doing everything. There's my little cone appearing here. Made a little hole in the pericardium, that doesn't really matter too much. There's an example of turning the 30-degree telescope upside down, looking from below. And then we'll see the telescope turn around again in a second. There we go, turn back down again, and then pulled up to complete the dissection. So once again, into the bag, and get the lung back up. Once again, post-operative, lovely x-ray, no diaphragm injury, and discharged the next day. Turned out to be a calcified hemangioma, a benign tumour, but that was interesting. Now, posterior mediastinal tumours are, I do a slightly different configuration. These I treat, I put them into a standard thoracotomy position, lateral position, and the ports I place the same way as we would do for lobectomy ports, except I use 3 instead of 4. So we divide the chest into thirds along the 8th interspace, and we put the right-hand port in anteriorly, the camera port's in the middle here, and the left-hand port there. We don't need the fourth arm in these cases generally, but you can use it if you need to. This is best if the tumour is more towards the apex of the chest. If, however, the tumour is more basally, then you can flatten out the ports this way, so you have the 7th, 8th and 9th interspace, and you'll see which is what I did for the next case. So this was a neurolemoma that was actually a dumbbell. The neurosurgeons needed to resect the pedicle, but we did the internal bit first, freed up the tumour. And you can see how versatile this is. This is using the hook. We can just chip away down here. And this is what I really wanted to show, just how delicate you can be here, protecting that nerve, just getting the tissue off the nerve above that we don't want to take, and continue that down. So that's the ideal configuration for a sort of a posterior, so an esophageal or like a leiomyoma or a duplication cyst, something like that. All right, I'm happy to take questions.
Well, thank you very much, Professor Gavin, for that very interesting lecture. We'll be taking the questions after the second lecture. So
Okay.
yeah, so we'll proceed with Dr. Aneez's lecture. Dr. Aneez?
Yep. Yes. How do I? You can see me?
Yes.
Good evening, everybody, and thanks, Edmund, for the kind introduction, and thanks, Prof Gavin, for helping us up with this lovely session. I'll be brief, and so that we'll have more questions at the end of the day. So a robotic team looks like this. Okay, so you share your space with many people who are equally, if not famous, like you. Okay, so it makes it a team game. You're not a solo hero anymore. So it makes many to build a block. Now, having said that, now you look at this person. This person is the first robotic citizen in the world, granted citizenship, looks like Sophia Loren, named after her. She is called Sophia. Okay, so someday this person will be doing surgery instead of you. And then the word robotic surgeon takes on a different meaning. Okay, so I'll quickly go on to the topic where we are, which is how you do or set yourself up for a lobectomy. Okay, I will cut down the audio, but I will lead you through my own comments. If you can see, this is how I position my table. So this is an placement of ports on the left side. You don't have any arm rest. You've taken it off. I just put a couple of towels underneath the left shoulder and I drape the arm. And then the other end of the hip is also fixed. So I have two straps which fix the hip and the shoulder. Then I flex the table all the way. So you can move the table and the patient won't fall off. And then till today, after so many cases, I still draw all these lines so that I never go wrong. So I count my rib spaces starting from 12 all the way on the left. So that's usually all my ports are on the 8th space. And because in Asians, the total chest volume is smaller, the most anterior part will be a little bit more anterior than normal. So I'd probably be in the 7th space, okay? Which you will explain by moving on to the next video, by what I mean. So if you look at this picture now, you can see all the ports which I put in. So which I'm pointing, this is for an SI model. So you have a 10 mm port, that is where your camera port is inside. That is your right hand, which is your dissecting arm. And that is your grasping arm. That's usually a 5 mm port if it is an SI, and it's an 8 mm port if it's an XI. And this one is your left hand. Now this gap between these two should be a minimum of about 10 centimeters. So placing my fat hand tells me that it's about 10 centimeters. And form a triangle to the crux of the camera and your left hand, and you get what you call your assistant port. Now, I use the assistant port for everything, meaning it is an assistant port, but I also use it for my gas insufflation. So there again, you should have your own definition of what you mean by robotic surgery. It has to be done by portal, the presence of ports, and there should be no making a hole and putting a head or one left eye inside to look through into the chest cavity. That is how they defile the VATS procedure. So for a robotic procedure, we have set definitions, which is called completely portal robotic surgery versus completely portal robotic assisted surgery. So there are two different definitions. Now, that was positioned for the intuitive robot. So I'm just going to introduce you to a little bit of democratization, which is happening in this month alone, my dear robotic colleagues. So we have two robots which have been launched this month alone. One is from Japan, it's called Hinotori, which looks like an intuitive, but they say it's got more degrees of freedom, and they say it's at half the cost. And there's a German robot, which makes it even more better. This is launched in Europe. It's got a CE mark on it. And this is also compact, all our tools which are coming into your trade. That's why this talk today becomes very important. So you're not only learning the principles of robotic surgery, and if you look at all these designs, they all are placed on the most advanced XI platform. So you're not going to relearn the machine if new robotic machine comes. I put these two slides up because I had some juniors asking, what happens if a new robot comes? Do I have to relearn it? No, not necessarily. Okay, but this is what we have right now. So this is a really advanced robot, I would say, of the generation, which is available for human surgery. This is the XI, as Prof Gavin showed you. It's got a trainer and a trainee console, and you have the operating table, you have the vision cart, and you have your assistant nurse. Now, this is how you dock. So you have your assistant, you have your arms to your dock. This is a table side assistant, and that's your nurse, and your anesthetist is removed. And so are you. You're sitting far away from the table with your head inside the cocoon. So you should understand that when you're doing robotic surgery, the correct term to say is called remote telepresence surgery. So you are sitting in a remote and you're connected to the operating table in terms of cable, which is telepresence. So you're not physically present at the operating table, which means that mentally you should be prepared for eventualities, which will happen. Let me quickly move on to this, which is basically, I'm not teaching you how to do an upper lobectomy here, but this is how an upper lobe, this is an upper lobe lesion. So let me go on to the video. So I usually start with forearms for lobectomy, and I use insufflation. As you can see, I get a lot of depth and I get a lot of space. We have dedicated thoracic equipments for lobectomy. So what I'm using is a thoracic dissector. The jaws are longer than a standard Maryland, and the bites are much smoother and easier to dissect. I always start by doing lymph nodes. Now, if you had looked at the video, you can see that nothing beats lymph node dissection other than robotics, because it is very clear. Everything is nearby, you hardly lose any blood, and then you can avoid all the mistakes which you tend to do even in open surgery. I feel robotics gives you a much better platform if you are a learner. Gone are the days where you have to say, oh, you had to be good in that before you're good in this. No, it doesn't work that way. With robotic surgery, you're actually doing open surgery with a much more better articulated arms and a supervision. So that you need to understand. Now, when you're working with a machine as an interface between a human hand and another human body, you need to understand how much pressure to put. That is a major problem about robotics, which is called haptics. We don't have haptics, but then you don't even have haptics when you do open surgery. You don't know how much to pull, and that is where you call all the things, all the problems. So as you gain experience, you will find that the robotics also gives you enough haptics for you to know how much to pull and how much to take back. I use only one energy device, which is bipolar. I saw Prof Gavin using the ultrasonic. The problem with ultrasonic, we lose the wristed part of the instrumentation. Okay, but with the bipolar, I think you retain your wrist, if not more than what a human wrist can do. Now, these are simple tools which are available for you, as you can see, which is a vascular loop. Cut them to usually about 10 or 12 centimeters. I have them in two sizes, depending on what I'm holding, either a blood vessel or a bronchus. They're all same standard cut sizes. And you can see two gauze lying down rolled well. I call them the cigars. They fit into my 12 ports now, which is what I use because I use the latest air seal from Transmedic. So these cigars are custom made, and they're also custom made because each cigar is weighed as a loss of 10 mils of blood if it is fully soaked. Now, because you have dedicated instruments for your own specialty, I would recommend to all of you people who are starting to understand that you should use the equipment which is available from Intuitive or DTG, because they are very specific to our field and it makes your surgery much, much easier. Okay, if you're going to fight the space with a smaller Maryland, which I used in my beginning of my career, I found that I used to make a lot more damage, traumatize the tissue as well. So these are custom made. You see, you just saw the thoracic grasper, which has just poked into the screen, which actually is an atraumatic grasper, which holds the lung down while we do other things. Well, you can see that the rest is standard part of any lobectomy, which you can see, and we will move on to the next one. So I'm not here to discuss lobectomy. Okay, this is also the same thing. This is with the much older robot. Okay, so let's get on with that. Okay, I will skip this part. I'm not here also to talk about, you know, benefits of robotic surgery versus VATS or open, because it's all been done and dusted. There are about 17,500 publications in the robotic space right now. So you can go and do, there are even meta-analysis studies, more than 14 meta-analysis studies comparing robotics versus VATS, robotics versus open, oncological outcomes, whatnot, in all kinds of space. It is all available. It's on the internet. You can read them. So this is a platform which is here for you, and this is for the future. And I think you should get on the bandwagon right now. Okay? But you should also understand that there are many more things which is coming into the space. Now, in the space, we have a competing person. He's called the pulmonologist. Now you have a robotic bronchoscopy, which is in operation since the last 4 months. If you've all seen all the videos and read through all the things, you can realize where that is going, because you have a bronchoscopy, which used to be not so accurate, now becomes 100% accurate because it is artificial intelligence and robotic guided. What if that tool itself becomes a robotic pathological excision tool, which you need to worry about? So I think these two people, the pulmonologist and the thoracic surgeon, may become a single entity probably 10 to 15 years down the road. So many of our juniors may need to be wondering where they're going and in what space. So I don't know how medicine will evolve in the next decade, but I'm pretty sure there will be a lot of competitive intermingling between a pulmonologist and a thoracic surgeon. So moving on to my next topic is, how do you get trained? My journey with robotic surgery started in 1999. I started off with a robot called ESOP, which is a voice-activated robot, which is the paternal grandfather of the Da Vinci. And because it was voice-activated, it was not made for Asian accents, defined for American accents, whatever that means. And it would never work in Asia. We tried to harvest IMAs, it was a big failure. I used to shout at the robot, then it used to turn after a while. So that's why robotics in the initial stage in Asia was a flop, and nobody believed in it. And then around the year 2000 and 2001, I think, the Zeus and the Hermes models, which is just the precursor to the Da Vinci, was fully functional. But they were all in a modular phase. What they put together of all these modules was the first robot, which is the standard module, which came around in about 2003, 2004. And as Gavin nicely put all those pictures together, these robotic models have evolved and to reach the current stage of an XI, which I think is a super model right now for any form of human surgery. Just because we keep developing newer models of robots, you're not going to increase the amount of robotic surgery being done around the world. How do you improve or increase the capacity of these instruments and make it available to the common man? The whole show is run by Intuitive. To be fair to Intuitive, they didn't choose, they bet on it, they won big, and there they were. It's the rest of the companies which needed to catch up. And interestingly, we find the big players, the so-called big players in the market, are very behind in the queue. As I just put on the two slides, you see a robot from Germany, a robot from Japan, there's one from Korea, and there's one from Canada. These 4 robots will be, by the end of this year, in the thoracic space, democratizing everything, bringing down the costs and making a huge difference. So what do we need to do? We need to increase the number of surgeons who are being trained, okay? And I think by increasing that, then you pass the message down to the next generation that this is the table you want to sit and eat on, okay? And it also needs a paradigm shift. How are we going to train our junior residents? To train a resident in robotic surgery, it is much less heartache than video-assisted surgery. It takes a lot of skill to do video-assisted thoracic surgery. And it doesn't take a lot of so much difficulty to do robotic surgery, because robotic surgery is like open surgery. You're feeding off the screen in a three-dimensional space. So we need to understand that probably that is also change our mentality, how we're going to train the next generation of surgeons. So how do we do? The problem is, again, I'm going to hark back into my journey and say, okay, I've been working with robots, but I could never get a certificate or any kind of recognition to come back home and say, hey, I can do robotic surgery. And how did we go about? So I had to travel myself. I worked with the European College of Thoracic Surgery at that time. And Franca Melfi, who's, by the way, a speaker for next week, don't miss that talk. She put up the first integrated course for robotic thoracic surgery. So there was a level 1, level 2, and level 3. And there were 2 participants from Asia, me and Alan Seho from Hong Kong. We completed the 3-part series. And then many of my peers today who are on the course, people like Mark Delevsky and Richard Lazaro, they're all like seriously gone on to do bigger and better things. But after that, that course was not sustainable because there was only one industry player and we didn't have the finances to sustain people from Asia. So it was only for Europeans. So when I came back, I had to go back to the US on my own accord to learn further, to expand my thing. And then where I found willing teachers in the form of Dr. Serfolio and Lazaro who helped me with that. So should we in Asia have a universal system based on the specialty which we are? I think so, because without which we will not be able to sustain a program for the future generation. So the question is how, who, and where. So I take pride and privilege to introduce to you today Southeast Asian Thoracic Society as an initiative. The directors of this school of the seats are, one is Dr. Edmund Villaroman, who is the moderator in this session, and is also Dr. Soon Sing Yang, who's also another moderator who will come upon later in the session. So what we want to do with you? So we're kind of developing a program with the help of sponsors so that we can offer a kind of fellowship, which Dr. Gavin put up there. So I'm going to just quickly go through how people who are listening today, who already emailed me about it, to listen through and then look into our website in the future. By the way, this is not yet approved by the Board of Seats. It's still in planning stages, but it should be up there soon. So I call it the 5-step to your certification in robotic surgery. So this is the first one, which you get the intuitive website, and then you read the technical parts of the SI or the XI model, and then you get a certificate from them. This is to say that, oh, you know the technological nitty-gritties of this particular working robot. So I've added a second sentence, which is a certificate of familiarity with the equipment based on the design and model of any other said company, because we see many other robots coming too. It moves on to the second step, which is to do your console dry run box practice and simulation. So nowadays, every robot which is sold with a console and a simulating model. So this simulating model will be there, which will help you to practice all kinds of procedures in your field, which is thymectomy, lobectomy, mediastinal lymph node dissections. So we have defined, this is based on the last AATS robotic consensus between robotic surgeons, that the pass rate for non-critical errors in your simulation should be greater than 90%, meaning you can only have 10% errors for non-critical, and you should have 0% error for critical ones, as defined by the computer when you practice your simulation. And that certificate has to be verified by a supervising surgeon, a proctor, or on-site representatives of the said robotic company. And which move on to step 3. So now you've got those two, then you have to attain a certified cadaveric workshop. Why cadaveric workshop? Because it actually tells you how to dock the robot, move in real time, move in the space, and you can afford to make mistakes there, okay? So it has to be under any certified organization with a conference or not, but this certificate workshop should provide you real-time working with the robot and the cadaver, demonstrating different thoracic procedures. And this certificate has to be submitted to qualify for the next step. So you have to pass every step to move on to the next step. Just go through some information. The first cadaveric workshop should be for seats for robotics should be coming very soon. We will advertise on the website. So step 4, it's divided into 2 parts. So which is what Gavin also said, which is stage A, where the participants with this team of nurses and anesthetists will visit the hospital, which we define by our society, which will be considered a center of excellence in robotic surgery, and will then be allowed to view procedures as deemed necessary by the participating surgeons. And in a stage B, which is the second part of step 4, the participant will be then chosen to do a fellowship attachment at a recognized center. So as part of our society, we are working with 3 countries and 3 different hospitals, which will allow you to participate, watch, and do 20 cases. 20 cases is defined as a consensus by the SRS, Society of Robotic Surgeons everywhere, for thoracic space, okay? And then whichever, either 3 months or 20 cases, whichever, if you go to high volume center, I'm sure you can finish those in about 2 weeks. Sometimes it takes longer in bigger centers. So whatever is done. But a logbook needs to be maintained, signed by your proctor and submitted before final certification, which is the last part, which we think we have added in recently. Step 5, which will include your proctor or the gentleman who trained you to visit your facility and watch you do 3 cases supervised by him, where he will not assist, just supervise you. And all the clinical outcomes should be documented, presented in the form of a logbook to the society and board. And the Society School of Thoracic Surgery and board will be the final authority regarding the competency to practice, based on all the things you've signed up to. So there are some of us who've embarked on this journey and who are practicing already. So I want to throw these for them. I'm very proud to say that Edmund is one of them. And I have Professor Win from Ho Chi Minh City, who started off and who's now, he's become a proctor by himself. He can teach people, very successful. And I'm also proud to say that we have surgeons from Malaysia, Dr. Adli, who's in the scene, who's getting up there. He's soon to complete his draftsmanship. And we have 2 people from Singapore already, and we have 1 more who's in the process of joining and finishing it too. So if you want to submit something to your institution, you can use this chart. This will be available on the website. You can see. So as you can see here, for me, for thymectomy and posterior mediastinal masses, I tell my institution, sorry, it's either robotic or open. I don't even bring video-assisted surgery into the equation. So because I feel that I can do a better job with the robot, not video-assisted. Otherwise, if it is that big or that complicated, then it has to go open. But for lobectomy and segmentectomy and complex sleeves, I have kept all the 3 options open because we know where the data is at this point in time. So if you want to put this up to your institution, this is one way to help your institution to embrace this platform. So what are the prerequisites for joining our fellowship program? You must be a registered member of Seed Society. If you have not done, please go to the website, get yourself registered. And your practicing hospital should have a robot. So DTG and Intuitive will tell us what kind of robot you have in your hospital and where you are. Every step must be completed in order before proceeding to the next. So you cannot sidestep each step. The directors of the School of Seats and the board members will be responsible for fellowship governance. All robotic platforms, this is not exclusive to DTG and Intuitive. All robotic platforms are welcome by our society to work with. That's it, actually. And thank you very much for listening to us on a Monday night.
Okay, great. Thank you, Dr. Aneez, for that wonderful lecture. So, can I ask the participants to type in their questions in the Q&A? So let me just start. Yeah. So, is it a prerequisite that you do video-assisted thoracic surgery before you embark on robotics, or is there any advantage of being a proficient VAT surgeon before you go into robotic? Dr. Aneez?
Okay. Okay, so you can think of it 2 ways. One, I think you go from open to robotic straight. So you don't confuse a VATS platform, which is a 2D platform, into a 3D platform. That is one way of thinking. But if you're already an experienced surgeon who knows how to handle a difficult procedure, as I said before, VATS is difficult in robotics, I think you're actually at an added advantage where your learning curve to the robotics is much lesser. But that doesn't mean that anything is a prerequisite of the other. Robotic is a standalone platform. There are no limitations to start at whatever time.
Yeah, I'd certainly agree with that. Particularly for lung surgery, I think the open experience and the robotic experience are quite similar. The views are very similar. The dissection is very similar. It's quite different to learning either the traditional 3-port VATS or uniportal VATS, which are very skillful procedures in themselves and require training in how to actually execute those procedures. The robotic platform is much more like an open surgery, using your right and left hand like you would with a chest that's open. So I agree with that. It's a bit different for the anterior mediastinal work because most people are used to doing a sternotomy. So they're used to having a flat view of the mediastinum with the sternum open, as opposed to seeing that view from the side, whether it be the left or the right side. But the view is actually better than you get at sternotomy, really, particularly looking at the nerves and things. You've got tumour overhanging the nerve, you actually get a better view. And I totally agree with Dr. Aneez that for me, it's either sternotomy or robotic for thymectomy or for, I have done 100 VATS thymectomies over the years, but for me, the robotic is the gold standard procedure.
Yes, Professor Gavin, have you tried using a subxiphoid approach for robotic thymectomy? I read some articles doing that kind of approach for radical thymectomy for myasthenia.
Yeah, I haven't. I've seen some videos of it that were very elegant and they look very good. But I mean, as Dr. Aneez says, I do uniportal surgery, we do multiport surgery, VATS surgery, we do robotic surgery, we do open surgery. To me, there's just a limit to the number of different approaches that I'm prepared to do it. Because I've got to teach these procedures, I've got to do them myself. So until each new procedure shows me a real stepwise improvement in something, I really just can't chase every single procedure. So I haven't actually done a subxiphoid approach, although I could see what a nice approach that could be.
Okay, so we have some questions here from Dr. Lamar Mohammed from Algeria, who was asking, can you tell us about the learning curve of a junior resident? How many hours of training, simulation?
I think the more junior you are, the faster you learn. Okay, so we took all our sons to the robotic training and they beat us hollow in about half an hour. So the earlier you start, Lamar, I tell you, the faster you learn. Okay, and how many hours of simulation? As we said, as long as the computer tells you you completed all the training simulations with 95% and above accuracy, that's it. That is all you need, nothing more.
Yes, I'd agree with that. It's a competency-based thing. Some people in 10 hours can become highly competent. Others might take 20, 25 hours to get the same competence. So it's an individual thing. And it does depend on things like having had previous VATS experience may help you in that, just the ability to manipulate tissues along, with remote instruments and things, so there are sort of advantages of having VATS experience, but I think the most important advantage is to have experience of the procedure you're doing, whether it be open or VATS, so that learning the procedure is not, because remember, the robot will not make you a good surgeon. The robot will just facilitate however surgeon you are. If you're a bad surgeon, it'll make you a robotic bad surgeon. Yeah. So you need to be good at the operation you're doing first, and then the robotic platform. It's not a difficult platform to learn, is my feeling.
So if you're starting to do robotics, would you recommend first doing like simple mediastinal surgery before you jump into doing lobectomies and more complex sleeve resections? Would you recommend doing that?
Absolutely, absolutely. I think thymectomies, things like small thymomas, 2 to 3 centimetre, wedge resections to start with, before you start doing lobectomies. Some people say, oh, that's a waste of a lot of resources, a robot to do a wedge resection, but that's how you get proficient at the use of the robot, the handling of the lung, the look and feel of it. Dr. Aneez talked about the lack of haptics, which is true, but what happens is with the extreme magnification and three-dimensional view you get, your brain becomes tricked into thinking you are feeling structure. So you actually will feel a firm lymph node, you'll feel the bronchus, because of the way it deflects is so accurate that your brain fills in the pieces and makes you think that you're feeling. So eventually you actually do trick yourself into thinking you can feel everything.
Okay, there's a question here. Are there any expected difficulties for a left-handed surgeon? I'm a left-handed surgeon, so is there any?
You can answer that, Edmund.
No, no, there isn't. No, definitely. There isn't.
Yeah, this is ambidextrous surgery. I would agree.
Exactly.
Left-handed you want to be.
In robotics, you understand you have 3 hands, my friend, so you can use more than one left hand, so it's all right. Okay, any other questions?
Yeah, another question here. How do you manage bleeding complications during robotic surgery?
I think, yeah, you go first.
The first thing is, A, don't panic, and B, you can actually put pressure on something with a robot. It's the world's best assistant. You can put a bit of pressure on and actually pull your head out of the robot, and the robot arm will just apply the pressure exactly as you place it. So as long as you can accurately identify where the bleeding's from, put your cigar or cigarillo onto that. In most cases, pressure for a while and going and doing, put pressure with one arm and then maybe do a bit of dissection somewhere else while you're waiting, or just simply take a time out. It's the same in VATS surgery, it's the panicking that causes the trouble. If you panic and start doing things, you can cause more trouble than just letting some pressure settle things down. And if you do have to open, you just leave the arm pressing, you take the other ports out, and you leave the telescope in, and you do a thoracotomy. And then you've got actual control, you've got vision, and you then just, once your hand's in, you take the robot out.
Dr. Aneez?
Just one sentence to add. Everything what Gavin said is absolutely right. No need to panic. You just need to practice this as well. You should have 1 or 2 dry runs with your team to say, okay, I've had a bleeding. How do you respond? Which includes don't panic, should be part of the dry run. Okay, there should be a nurse who understands what's going on, get a thoracotomy set going, blah, blah, blah. You may not need it at the end of the day, but it's good to have a formula written down and a dry run with your team. As I said, there are many heroes in robotic surgery. You're not solo. So if you practice this thing, it becomes the norm in the operating theater.
Okay, a question to Prof Gavin. Have you had any use of using the firefly fluorescence imaging for mediastinal surgery? Is there any benefit of using that?
Yes, I do use firefly for several indications. In fact, I'm giving a webinar, one of the speakers next Saturday, on ICG and fluorescence. Excuse me. So I use it for, you can use it for sentinel node detection, just to see if you want to send off, for example, if you're doing a segmentectomy, I want to see what node is being first drained to. I want to send that node off to make sure it's negative. Or I use it to work out where the segments end. So I actually can inject, after taking the vein and artery, I can get the anaesthetist to inject ICG and everything will light up in that lobe except for the segment that I'm taking out. And so I can actually work out where to place my staple lines. And the third thing I do is localization of peripheral lesions that are small, impalpable. So I actually do navigational bronchoscopy and mark those spots with ICG. And then when you turn the Firefly on, that spot will fluoresce on the surface of the lung, and you know where to wedge resect those. So there are three things I do with ICG and Firefly.
Have you used it for identifying the contralateral phrenic nerve? Is there any benefit of doing that? I've read some articles about that.
Yeah, I've heard of that, but I actually haven't done it. And maybe I should actually do a few of those, just have a look.
Dr. Aneez, any use for the Firefly in your practice?
In large thymomas, if I'm not able to pull the pericardium to see the other side, then I do the Firefly with the dye to see the opposite phrenic nerve. So I do use it. Or only in very large thymomas.
Okay, there's a question here. If you want to start robotic surgery program in our center, should we buy the latest robot or the old, cheaper ones? Question.
Okay, good question. So it all depends on how much money you have, right? Okay. I think anything from SI onwards is a good robot to buy, but you should also understand that Intuitive will not sell you old model robots anymore, my friend. I'm sorry. They have stopped, they've changed their policy, so you cannot buy old robots. And also be careful if you're being conned into buying an older robot, because you may not get a service agreement for you to use those instruments. So be very careful, consult with DTG, speak to them, and then go ahead and buy.
I think the X is a good compromise because you get the XI platform sort of from the waist up, and you get the old SI platform. It doesn't have all the bells and whistles, but everything that I like about the XI is on the X, really.
So has there been any change in your practice of robotic thoracic surgery during this COVID times, during this COVID-19 pandemic? Is there any change, like, smoke evacuation, other precautions? Is this robotic an ideal platform during this time of the pandemic?
I use AirSeal.
AirSeal.
Yeah, I use AirSeal. So when you use AirSeal in combination with robotics, one, you keep the robotic whole thing completely portal. And AirSeal is a very good demonstrated scientific viral filter. So I didn't have to change my practice for COVID times, to be honest, at least the robotic part. Yeah.
Yeah, I haven't actually changed my practice, I'd have to say. And if you're doing mediastinal work and you're not touching the lung, then you're not creating an aerosol from lung. So I don't think that matters. I suppose lobectomy, potentially, if you're opening the airway. I mean, all our patients get tested for COVID-19. They get a questionnaire before they come in. They have to self-isolate for a week. So the risk of us operating on, well, not just for our own sake, but we certainly don't want to do a lobectomy if we can help it on a COVID-19 patient. The mortality is very high. So I think it's a theoretical question, but in practice, I don't think we really change our practice for in this era.
There are some surgeons trying to do uniportal robotic lobectomies. Do you think it's going to be, it's going to be done in reality, basing on the current technology that we have? Is it going to be a thing of the future, single port robotic surgery?
I think it's quite possible. I mean, uniportal surgery is the most common form of lobectomy that I do these days because I have a certain amount of access to the robot, so I'll fill up the robotic spaces wherever I can, but the rest of my operating is done uniportal. And I must say the uniportal probably is the least painful of all the operations. So if we could get the robotic, uniportal takes a lot of skill. If we had the robotic equivalent of uniportal, I think that would be fabulous. So I think it's certainly a possibility, and I think if it was carefully engineered, I think it would take off.
Okay, that's great. Have you tried using the synchro seal by Da Vinci? The energy device by Da Vinci?
Yeah.
Aneez?
Yes. It is pretty good. If you're doing esophagectomy, it's my go-to.
Mm-hmm.
For esophagectomy, it's a go-to thing. You should try that if you're doing segmental resections. For going through parenchyma, that helps too. Okay, some spaces. Large mediastinal, you can, yeah. But you should understand that there's an added cost to it. So that is an issue. If you're not mindful of that, then I think it is a good tool to have in our. It is great for esophageal surgery. Number one choice.
Yeah, I would agree for esophageal surgery. It's good. I prefer the either the bipolar Maryland style or the harmonic for general dissection, because they're much finer, whereas that's quite a chunky instrument. Very good for esophagectomy, you know, taking big chunks up the side of the. But for finer work, I would say that it's not my go-to instrument.
Okay, what case, Professor Gavin, would you say you'd go outright for an open procedure rather than doing robotic, other than of course large mediastinal tumors? What about invasion to the pericardium or other structures? Would you opt to do open instead than robotic, or would you still attempt to do it robotic?
Look, yeah, obviously a very big tumor, which is going to give you access problems. Also, you don't want to spill a tumor. You know, a big tumor, you've got to get it into a bag, and you don't want to end up breaking the tumor, getting into a bag. So there's a point where you just say, okay, look, let's call it quits. We'll just do a stenotomy for this one. I think just specifically invasion of the pericardium, that's not a reason not to do a robotic approach for me. Very easy to resect very widely the pericardium, no trouble at all. You can even suture in a patch. The robot's perfect for suturing in, doing any suturing. So, and if it's just a small piece of pericardium just to get a margin, you don't have to do anything, it's just a small defect. That in itself wouldn't stop me. And even I've resected tumours that have invaded the brachiocephalic vein, even the edge of the cava. If it's just a small amount of invasion to the cava, you can resect part of the cava. If the phrenic nerve's involved, well then it's gone anyway, so you can resect whatever you need to in the pericardium and the caval area. So I think size, and obviously if you're dissecting, having a trial dissection, and you have a look into the pericardium and you see something's invaded into myocardium, then obviously I would abandon the robotic approach there. It may even abandon the entire approach, but certainly I wouldn't continue if I had invasion of a pulmonary artery or a myocardium, something like that.
Okay, so there's a question here. What textbooks would you recommend to start learning about robotic thoracic surgery? Any recommendations?
There are some good books for robotic surgery. Most of them are online. They are available online. There are a couple of dedicated textbooks. We will put it up on the SEATS website. Bear with us. We will give you access to that as well. So it will be available, and they are really go-to textbooks. I'm pretty sure that if you don't miss the next week's lecture, there will be a couple of authors are talking on the platform, so you can also ask the questions to them.
I would say online videos are probably my go-to rather than books. CTS Net or Lazaro's videos are fantastic. If you want to, and Sofolio, people like that. Watch their videos; they're fantastic. Yeah.
Okay, so yeah, okay, very interesting discussion. Final word for those, those who want to pursue robotic surgery. Any words to encourage them? Because some would question, doing robotic surgery is an added cost. You can do it with other means. So how would you encourage other beginning surgeons who would want to embark on robotic surgery? Professor Gavin?
Well, if robotics is already present in your hospital with urology, gynecology, GI surgery, then really I would argue the business case that the amortization of that robot is more efficient if you're actually doing multi-specialty platforms on it. So you could say, well, the incremental cost of us doing robotic surgery really boils down to the instruments. And I try and keep my instruments as efficient as I can. I usually only use a couple of instruments. I don't sort of use the entire range of things on one case. So for a thymectomy, for example, I just use the one harmonic and the one bipolar. Occasionally I use a clip applier, but in our system, the cost of a clip applier is going to be paid for whether you use any commercial clip applier or thoracoscopic clip applier is probably about the same cost. So obviously, if cost is an absolute problem, then uniportal surgery is what you'll have to do. You don't do robotic surgery. But it does mean you miss out on what I think is the gold standard for thymectomy. I think robotic for me it's number one, then daylight, then open, then VATS.
Okay, thank you very much. Dr. Aneez, any final words?
Yeah, I think if you're between 30 and 40, you should be on the robotic platform because that's your future. If you don't, you're going to lose out. And then there's no point cribbing about it because the robots are in the field already. And it's just a matter of time when the prices will go down. Okay, so I'm pretty sure when it is democratized, and then there's no point looking for a thing when there's already water under the bridge. So if you're young, if you want to be on the robotic platform, now is the time to get on the robotic platform. Thank you.
Oh, thank you for that very fruitful discussion we had. So let me invite our participants and faculty for next week's webinar. We're still going to have topics about robotic segmentectomy and also complex mediastinal surgery. We have, again, two distinguished speakers, Dr. Robert Serfolio and Professor Franco Melfi for next week. So again, thank you very much, Professor Gavin Wright, for that very nice lecture. Dr. Aneez, again, thank you very much. So we'll see you again. Okay. Thank you very much.
Thank you, everyone. Thanks, Gavin. Thanks for helping out. I appreciate it.
Yep, my pleasure.
Thanks, Edmund.
Okay, bye. Stay safe. Bye.